Today's sponsor is Ava. Did you start trying for a baby thinking that ovulation was your one and only chance each cycle? It's not. In fact, there are 6 days a cycle when it's possible to conceive, the 5 leading up to ovulation and the day of ovulation itself. So how can you make use of that fertile window when you don't even know you're in it? That is when Ava comes in. Ava is a sensor bracelet that detects subtle changes in your vital signs that correspond with the opening and closing of the fertile window. All you have to do is wear Ava while you sleep and sync to the app in the morning to see 5 of those fertile days as they're happening. And right now, it is $20 off for the Sisters in Loss listeners. Just use the code AVA Sisters at avawomen.com. Once again, use the code AVA Sisters or AVASISTERS at avawomen.com. Well, welcome, Brianna, to the podcast.
Thank you, Erica, so much for having me. I'm delighted to be here today.
Yes. And for the month of May, to all our listeners, our podcast is sponsored by Ava Women, and we have a special guest. I wanted to talk all about COVID-19 and vaccine. So as many of you all know, because we've been living through this pandemic, we're a year removed from the beginning of this pandemic. And I feel like, at least here in the US, we can see the light at the end of the tunnel. So many of our listeners who may have had fertility treatments placed on hold or have been giving, kind of the runaround around what it looks like from a pregnancy perspective through COVID. Now they're starting to get more comfortable of taking the additional risk of maybe possibly getting vaccinated prior to treatments or, in their pregnancy. And a lot more people are just being way more cautious overall about COVID-19 and how it pertains to how they're moving about around town, around their jobs, being able to see family members. But I feel like we're seeing that light at the end of the tunnel as more people are getting vaccinated within the US and really around the world. So I really wanted to have a conversation about this, guys, because we hadn't talked about it. We've talked about it from different perspectives of people who've had COVID on the podcast or may have been affected by COVID, with people who may have lost individuals, family members, even their babies. But I wanted to talk to an expert to really talk about how, what are the guidelines and give us a 1-2 place to go and some resources so that we can make informed decisions for ourselves. So that is why Brianna's here. And I'm so honored that you agreed, especially with our partnership with Ava, to really talk about, some of the research and the facts and the findings and the data, the things that we love as science people.
Yes. Yeah. I think you're politely telling me I'm a giant nerd, but that's okay, Erica, because I 100% am. So
we can nerd out together. I am too. And I think that's the part about it that I love about this is because, obviously I'm very much so, as just being a scientist, as an engineer, I want to see the numbers. I want to see the trends. I want to know how this can apply to me, because what we've seen, since the beginning of COVID and what we've known is that, a lot of Black and Brown communities are negatively and adversely affected by epidemics and pandemics, in general. So, I want us as a community to really be informed about, what we're putting in our bodies, but also, what does the data show and what is it leaning toward based on the evidence that has been gathered over the last year. And it's still, obviously still moving. So I would love for you to just really talk about starting out as I kind of led us up to this. What are some of the guidelines and recommendations for COVID-19 vaccinations for pregnant people or folks who are like in that trying to conceive window?
Sure. Yeah. So Thanks again, Erica, for having me today. Just to give a little bit of a caveat, again, being a scientist, I want to know kind of always who is my data coming from? Who are my sources, right? So just to level with your listeners, I'm Brianna Goodale. I have a PhD in clinical research from UCLA, and I have been working as part of AVA's clinical research team since 2017. So I was drawn to AVA because of the science. Like you said, I'm very much want to dig into the data and understand where it's coming from, what it's saying, and be informed. So AVA, for those of you who aren't aware as listeners, is a wearable fertility tracker. It was designed specifically to help women leverage machine learning technologies, so algorithms, data science, as well as what we know from clinical trials and biophysical parameters, so biofeedback, to give an individualized fertile window. So I was someone who was diagnosed with pelvic inflammatory disease, unfortunately went through a lot of treatments for that, was told by my doctors, you may or may not have uterine scarring, and good luck getting pregnant. We'll see you in a year. A very little explanation of what I should or shouldn't be looking for, how I would or wouldn't know. Being a scientist, that wasn't really good enough for me. I wanted to understand why, and if I could jumpstart the process of looking for fertility treatment options, do that sooner. Long story short, I found AVA, was really interested by the kind of science behind it, of how we can leverage wearable sensor technology, and started getting so into it, even though I was using it, I was really loving it, and ended up applying for a graduate level internship position. Got the position, really was that much more thrilled to be part of the science, and have been with the company since. So over the last year, my position has shifted from more of a clinical research, scientific communication role, generally about our fertility research, to more of a AVA-COVID specific, looking at specifically, instances in which we can use a AVA bracelet and a wearable fertility tracker to better understand how COVID might affect heart rate, breathing rate, skin temperature, all of those things. So I have been doing that over the last year. We've launched a couple studies on that. And so although I am not a member of, say, the CDC or WHO or a medical doctor, my research over last year has been very much in the forefront in understanding what are different parameter changes look like for COVID, how does the virus work, and how does the vaccine impact all of that. So I wanted to just give a little bit of background so that your readers understand that I'm coming from this kind of intersection of both fertility and women's reproductive health research, as well as COVID-19 specific research. So all of that said, to get to your question about the guidelines that are out there, as your listeners probably know, especially very early on in the pandemic, there wasn't a whole lot of clear guidance around what was happening with pregnant women who got COVID-19. And then as vaccines came onto the scene, what was or was not the recommendations from some of the big organizations. So specifically here in the US, some of that has been clarified over the last couple months. So the Center for Disease Control out of Atlanta, the CDC, they actually are, they're very upfront about the fact that we have limited data around women who are pregnant who got the vaccine. So currently in the US, there are 3 emergency use authorized vaccines. That's the Pfizer, Moderna, which are mRNA vaccines, and then Johnson & Johnson vaccine, which is a more typical adenovirus vector vaccine. And they look a little bit different in how they work in the body and also their kind of dosing schedule. But none of those 3 have specifically run trials on pregnant women to look at the effects of the vaccine, either its side effects for when you get the dose and you have an immune response, to how it's affecting pregnant women and the fetuses as well as the neonates when they're born. Those trials are supposedly in development. So that's why the CDC has come out and said we have really limited data about this. We don't know because there hasn't been trials specifically designed for this. But the CDC then says it's unlikely to pose a risk. They give this kind of caveat because we do have some very initial animal studies looking at like rats and rabbits and mice showing that these vaccines, they don't appear to have any safety concerns in these pregnant animals. So that's not to say that we as women should equate ourselves to rats or mice or rabbits, but it is just the very first step, the baby step that needs to be done before we can then say, okay, the vaccines are safe enough to test in pregnant women in a large scale trial. We do, however, in the last year also have Be Safe, which is the CDC's big tracking registry for anyone who's ever gotten the vaccine. Through that, they've been able to actually look at data from women who were either pregnant and didn't know it at the time they got the vaccine, or got the vaccine while they were pregnant in their first, second, or third trimester, and have reported and published just this past week their very first paper about the results of that. And again, the data there is really seems to suggest that there's no additional safety concerns for pregnant women getting the vaccine. The CDC does encourage women to consider having a conversation with their healthcare professionals about their own specific instances and considerations. So some of the things the CDC says to consider are things like your exposure risks. So are you a healthcare professional who's out, a nurse or a doctor working with patients who might have COVID-19 and therefore at higher risk? Or is there a high level of transmission in your community? So those are basically things to consider in and of themselves. So that's the CDC. I'm also happy to talk about the World Health Organization. They are, a health organization who give guidelines for all countries, so not just US focused. But they also similarly say, while there's not enough data, they believe that if the benefit of the vaccination for you personally outweighs the potential risks, then it is recommended on their end that you get it. So we do know that the pregnancy, and we can talk about this a bit more too, pregnant women who get COVID-19 are at an increased risk for more severe outcomes. And so it's generally considered, especially by, say, like the big conglomerates of doctors in the United States. So these are all like the experts in the field of obstetrics, gynecology, reproductive endocrinology. Their big associations have said from their perspective, and again, these are experts in this, they do not think that the risk of the vaccine outweighs its benefits. They strongly encourage that women who are pregnant not be withheld or ineligible to get the vaccine. So they say, if you want it, you should be able to get it. So that is specifically the American College of Obstetrics and Gynecologists and the American Society for Reproductive Medicine. And then I also found some interesting stuff that came out. They just had a study published actually last week on the CDC registry, the VSafe registry, and they talked about specifically outcomes for pregnant women and babies and what they found.
So let's talk about that. Let's talk about breaking it down by race. What has happened within the Black community? A lot of people were initially, when the vaccine came out, right after the election at the end of last year, they were pushing back on receiving the vaccine just due to systemic issues and vaccines that were given, not that long ago, but it's had an effect on how the community as a whole trusts the medical system. So an example would be the Tuskegee experiment and, injecting, a lot of Black men in the Tuskegee area, Alabama area with syphilis and just studying them without providing them the antibodies to save their lives. So from that has had a ripple effect amongst generations, from that generation on to the generation now, where many Black and brown communities may not trust the healthcare system because of that experiment in particular. Obviously there are many more things that have happened that are terrible. But the system as a whole, people may not trust this COVID vaccine because of those systemic issues and underlying racism in our health system. So I would love for you to really talk about how the breakdown has been from a COVID vaccine by race and which you have found in the research that's available with the CDC, as well as the possibilities for, really just mainly just the breakdown of the race.
Sure. Yeah. No, I think it's really important, Erica, especially when you consider that women's reproductive health in the field of OB-GYN, right, is often credited to this one gentleman who unfortunately did most of his research on enslaved Black women who may not have did not have consent in those situations, right? So I think it's both, the vaccine front and then also women's reproductive health. We have historically seen those disparities. And so when I looked into it a bit, American College of Obstetrics and Gynecologists actually had a section where they were very transparent about the breakdown by race for the clinical vaccinations. So specifically for the ones that are authorized in the United States, about 10% of the individuals in the Pfizer biotech, if that's an mRNA vaccine, were Black, while another 26% were Hispanic or Latinx. The numbers are pretty similar for the Moderna vaccine. So again, about 9.7, 10% of Moderna participants were Black and 20% were Hispanic Latinx. And then it's a little bit
a little bit different, the adenovirus vector, the J&J vaccine, the Johnson & Johnson. So 13% of those participants were Black in those trials and 15% were Hispanic or Latinx. And what they found was that the vaccine was equally effective among different demographics, including race and ethnicity. So that is not as equitable as one would hope to see, but I think it is a baby step improvement, and there is some acknowledgement that race can be an important factor in how individuals respond, as well as an area that needs more consideration and study.
Today's sponsor is Ava Women. Did you start trying for a baby thinking that ovulation day was your one and only chance each cycle? It's not. In fact, there are 6 days a cycle when it's possible to conceive, the 5 leading up to ovulation and the day of ovulation itself. So how can you make use of that full fertile window when you don't even know you're in it? This is where Ava comes in. It's a sensor bracelet that detects subtle changes in your vital signs that correspond with the opening and closing of the fertile window. All you have to do is wear Ava while you sleep and sync the app in the morning to see 5 of those fertile days as they're happening. Ava is better than other methods because LH test can only tell you 1 or 2 fertile days. Taking your temperature only lets you know after you've ovulated, so it's not helpful in real time. And period tracker apps only guesstimate your fertility based on genetic averages. Plus, Ava's technology has been clinically tested and cleared by the FDA. So if you're trying to get pregnant, remember, you've got more than just ovulation day to play with. Let Ava tell you your best 5 days to conceive. And right now, it is $20 off for Sisters in Loss listeners. Just use the code AVASisters at avawomen.com. That is AVASISTERS, Ava Sisters at avawomen.com. Let's talk about really how the vaccines work. And then I would love for you to talk about just how it works as far as providing antibodies, especially for those who are pregnant or those who are lactating on the other end, if they do make the decision to get a vaccine.
So right now, there are 2 types of vaccines that women in the U.S., especially pregnant women, are eligible for. One is vector vaccine. So this is the Johnson & Johnson. Over in the European Union, this is the AstraZeneca vaccine that's been approved there. And we'll start there because that's the kind of more traditional vaccine. So how the vector vaccines work is that they take an existing virus that's out there. So in the case of the COVID vector viruses, it's the adenovirus. And it's relatively harmless virus that you might encounter, quote unquote, in the wild that would give you more of like a mild cold, for example. And they actually modify that virus, the adenovirus, and insert into it a piece of code, so some coding from the COVID-19 virus that gets the virus to create what is called a spike protein. So the spike protein is unique to this COVID-19 virus in the sense that it is a specific way in which the virus binds to the cells within your body. And so instead of trying to inject people, say, with like the live virus or attenuated, meaning like less, a weaker strain of the virus like we do for, say, measles, mumps, rubella vaccine. The idea is that we're not going to insert people with COVID-19. Instead, we're just going to take a piece of it, the spike protein, which is how it enters our cells, and replicate that in a more mild virus. So that is what is injected into the virus in the Johnson & Johnson vaccine. And what it does then is your immune system, when it sees this new adenovirus with the spike protein, it actually then starts to identify that spike protein and say, okay, we have to make antibodies to that spike protein specifically. And what this allows it to do is when it then sees, say, COVID down the road that has this exact same spike protein or very similar spike protein, your body's already trained and knows to say, aha, I need to attack that spike protein. So it doesn't have to learn that that spike protein is quote unquote bad or harmful in the way it would be if you were not inoculated or not vaccinated against it. But it does allow it to say like a first glimpse at it and recognize it. So that's the vector vaccine. If you think about it that way, it is introducing the spike protein via a pre-existing virus that we know to be relatively harmless. Now, this new class of vaccines that have come out and that have been widespread and launched really in the COVID era are the mRNA vaccines. This has been technology, though, that's been developed starting as early as the 1990s. So it's been in development for about 30 years. So that's where, you hear it's new, but it's new in the sense that it's new on the market for COVID-19. The reason it took so long to get from its original state of development out into the market was because what it's doing is it's taking, if you think of a blueprint. So we talked about the spike protein relationship to the Johnson & Johnson vaccine, and that's the same protein that the mRNA vaccines are targeting. But instead of putting it in another virus that you are, willingly infecting yourself with, so to speak, you're taking just that blueprint, just the messenger RNA, you think of it as like a blueprint code, and inserting that into a little capsule that then lives in, it doesn't live, but it is then in the vaccine and is vaccinated into an individual. So you're not actually putting a virus into a person with this vaccine. It is just the messenger RNA. And what this little blueprint does is it goes into your cells and it says, hey, host cells, so Erica cells or Bree cells, go ahead and create this spike protein on yourself. And so it again is showing your immune system this spike protein without any sort of virus. So you might hear that people have side effects from getting this vaccine. Think, well, how can they have side effects if they're not getting actual virus? That is just the immune system's response to a novel protein in the body. What is interesting, I think, pretty great about this is that researchers are fairly confident that this actual messenger RNA is unlikely to cross into the placenta of pregnant women and affect the fetus because it's not, it can't last that long in the body. The messenger RNA breaks down pretty much as soon as the cell has created the spike protein. So it's not like it's going to go then and cross the placenta and affect the baby directly. It's also not going to change your personal DNA. That's not how the messenger RNA vaccines work. So these two separate types of vaccines, the vector vaccines, the Johnson & Johnson, the mRNA vaccine, which are Pfizer and Moderna. So again, both of these, though, are prompting an immune system response that is trying to build T and B cells so that the next time your body encounters something with a spike protein, i.e. COVID-19, it knows what to do. It doesn't have to learn how to respond to that. I think the next question you had was about antibodies, right, Erica? Does that make sense? Or do you have any follow-up questions about the vaccines themselves?
No, that's perfect. Yes, I want to talk about antibodies because for those of us who want to make the decision to get vaccinated, there are possible antibodies that are showing that could pass on through pregnancy, and then folks who are lactating and breastfeeding or chest feeding that can pass on through the milk to their infants.
Great. So I'm really glad you asked about this because I think this is one of the things that fascinates me most as a researcher in women's reproductive health is just how amazing pregnant bodies and our reproductive systems and organs are at synergistically like pairing with the immune systems of our neonates, both while they're in the womb and then also once we give birth for women who choose to breastfeed, the impact that can have on antibodies. Some really recent research that came out looking at women who were pregnant and then gave birth. And what they were looking at is women who actually got COVID-19. So this is not necessarily vaccination, but it's COVID-19. And they look specifically at what is called IgG and IgA antibodies. So the IgA and IgG antibodies are two different types of antibodies that show up differently in the immune system. So IgA tends to, along with IgM, peak a lot faster, and it happens more in like the nasal respiratory tract generally. And then IgG tends to be more of like a lower respiratory tract, and it's also what you're looking for in terms of long-term immunity. So that's the one that more often translates to long-term immunity. Again, I'm going to give the caveat that these are big generalizations because we are still learning things about COVID on the fly, so to speak. But this is generally how IgA versus IgG antibodies exist. And they're not just specific to COVID, they're across all sorts of viruses. But what this study did, they looked at 88 women who were serology positive, so meaning they had a COVID-19 infection, and they looked at both the COVID-19 specific IgA and IgG antibodies in those women between March 2020 to May 2020. And then they also looked at the umbilical cord blood sample. So they took blood from the umbilical cords of neonates who were just born. And then they looked at that blood to see if there were any antibodies there related to SARS-CoV-2, the virus that causes COVID-19. And what they saw there was they actually saw no significant levels of IgM antibodies in these neonates, but they did see a significant level of IgG antibodies. These are the long-term ones, the ones you want for long-term protection, suggesting that women who had gotten COVID-19 during pregnancy had passed on some immunity to their newborns, to both probably the fetus as well as inside the mother and then the neonate. Furthermore, the neonate level of IgG corresponded or correlated with maternal level of IgG. So if the mother had really high IgG levels herself, the neonate was likely to have high levels of IgG as well. So I thought that was just a really interesting study because it just demonstrates that although it was COVID-19 virus specific, the likelihood of, when we get a vaccine, what we're doing is trying to stimulate the virus's ability to create in the body these IgG antibodies. So we have strong evidence to suggest that getting a vaccine against COVID-19 does elicit, an immune response in pregnant women. We have some data from VSAFE from the CDC that recently came out suggesting that. And then furthermore, has strong implications for and is likely to suggest that the neonates born to these mothers who've been vaccinated will also have those antibodies. So there still needs to be more research done around, the right, so to speak, timing of it so that you maximize the protection for the mother as well as protection for the neonate. But nevertheless, it suggests that there is a positive effect if you are someone who does unfortunately get COVID-19 during pregnancy or does get the COVID-19 vaccine, that it could pass on this protection for your neonate, for your newborn. The next one I want to talk about is the breastfeeding sample. So these are women who had their breast milk that they were actually sent out to these researchers. They sent out samples of breast milk and they got it before and after vaccines. This was a vaccine specific study. So they sent these samples out and it was a prospective cohort, meaning that the researchers designed the study up front. So as not to introduce any potential bias. And there were 84 women in the study, and it took place in Israel between December of 2020 and January of this year. It was specifically the Pfizer vaccine they were looking at, and here they looked for IgG and IgA levels. And what they found was that the IgA antibody levels for COVID-19 increased rapidly in the breast milk in the 2 weeks following the first vaccine dose. So 62% of the samples in those first 2 weeks tested positive for IgA antibodies. Remember, these are the ones that are more localized to the nose and upper respiratory tract. And this continued to increase so that by week 4 after vaccination, 1 month following vaccination, 86% of those samples had positive IgA antibodies in them. So this is, again, antibodies that are being secreted through the milk and passed on to the newborn through the breast milk. What I think is even more exciting to me and promising is that these antibodies continue to be elevated through follow-up, including at week 6, although they decreased a little bit. But interestingly, the IgG, so the long-term immunities, that actually took a little bit longer to rise. But by week 4, 92% of the breast milk samples tested positive for IgG antibodies and 97% by week 5 and week 6. Meaning almost all women who gave breast milk samples after vaccination had IgG COVID-specific antibodies they were passing to their children. So I just thought that was really amazing. And again, we know in the community, and there's been research previously about how women can pass antibodies on to their children when they are nursing and say get sick with some sort of, either regular stomach bug or the flu, and that can be protective for the children. But we have been, scientific community being able to document for the first time that this does indeed happen, and strongly so with COVID-19.
Perfect. Such great information. So I would love for you to give us some questions that we should be asking our providers, whether that is our fertility specialists, reproductive endocrinologists, our OBGYNs, especially for those who may have autoimmune disorders, past pregnancy complications, experience loss, how they should approach getting this vaccine from a personalized medical perspective, because I feel like, we've seen a lot of the data out there specifically on why people should get vaccinated, but a lot of folks, it's not a one size fits all. Like a lot of people might have underlying conditions that may not meet this bill for the first set of vaccinations. They may have to wait a little while for more, data and testing to be done based on their own personal situation. So what are some questions that we should be asking if we kind of fit into that category story and are unsure about making the decision to get vaccinated?
Sure. I'm really glad you brought that up, Erica, because it's so true. I mean, that's, I think, one of the big takeaways for women's reproductive health overall is that it's not one size fits all, right? And so some of the things that I think are worth asking about or considering in conversation with your medical professional is, again, the first one I mentioned earlier was exposure risk. So this idea of how much are you personally at risk? I have a colleague who lives in Denmark where it's something like less than 0.005%, or it's like 0.004% test positive for COVID on a given day. So for them overall as a country, that exposure risk is really, really low. They can go safely about their business. Where I'm living in Utah, the test positive rate at one point in this pandemic was 15%. So the exposure risk was really, really high. Even for me, someone who is not, say, necessarily on the front lines of the healthcare in the hospitals, et cetera. So it's both kind of personal exposure risk as well as like your exposure risk within the community are things to consider and talk through with your doctor. Another thing to talk about is the risk to you personally of COVID-19 if you are infected. So we know from some research that came out of CDC that women who get COVID-19 during pregnancy have significantly more severe outcomes than women, even when matched on race, BMI, and pre-existing conditions. So they're at a much increased likelihood of being ventilated, needing invasive ventilation. It's almost 3 times as likely, admitted to the ICU, and unfortunately have a 70% risk of dying compared to women who are not COVID-19 positive, who do not have the virus, but are matched for, all sorts of other confounders. So, COVID-19 is really serious. And it's one of the reasons that among pregnant women, the CDC has listed them as a high-risk group on their website. So there is that. There's also information about data of the vaccination that you should, take into account and talk over with your doctor. So, for example, one of the things that, I was cautious about, my partner and I want to have another kid, but I have really severe anaphylactic allergies, and getting an anaphylactic reaction while pregnant can be really bad and can actually result in loss. And so for me, I knew I wanted to be vaccinated. That was a choice I made based on my, just personal decisions. And I knew that I needed to have it before my partner and I tried to conceive again, because I wasn't sure if I would have a bad reaction. There is a very small percentage of individuals who do have an anaphylactic reaction to the Pfizer and or Moderna, more so Pfizer than Moderna, but that was a consideration. It's very, very rare. It's like less than 5 women or 5 people in a million. So thankfully, I did not have that reaction, but it was what drove me to do it prior to getting pregnant. So that is something I think to consider, again, individually, what are your circumstances? I anecdotally as well, I have a friend she's 39 or 40 weeks pregnant right now. And she got her first dose of the vaccine, Moderna vaccine, about a month ago. And she was set to get her second dose this week. And she pushed it back by a couple of weeks, again, with the consent of her doctor, because she did not want to have any sort of fever or side effects that can happen while she was set to go into labor. So, these are all to provide some context to that. There's no one size fits all. It's really about what works with you individually. I will say that the American College of Obstetrics and Gynecologists has said that they haven't seen any reason not to give RhoGAM, which is if you have some blood incompatibility between you and your fetus in the womb, you may need a RhoGAM shot. That's not contraindicated. That's okay to get along with a vaccination. They also said there's no need to delay pregnancy or trying to conceive after you get a vaccine. So there was initial questions like, do I have to wait a certain amount of time? The answer appears to be no. ACOG does not say so. And they also say if you find out you're pregnant between the first and second dose of an mRNA vaccine, it's okay to go ahead and get the second dose. So based on the experts and the medical professional recommendations overall, and it seems to be encouraged that pregnant women should think about getting the vaccine and see if it's the right fit for them, given the other parameters. I will also just give a caveat that I did share with Erica, and hopefully with your listeners, you'll be able to find links in the podcast notes. But we have the documentation you can read yourself from these organizations. So ACOG and ASRM, that's all public information. And I am all about empowering women to get into the data and the information themselves. And don't hesitate to bring that with you when you have that conversation with your doctors. Because doctors, just like all humans, vary in their level of informedness, right? Some may know more than others about the current state of research. So definitely don't hesitate to dig in, and ACOG and ASRM are both good resources for this.
Perfect. Well, I would love to end by talking about what AVA does and how, the research that you're doing is helping with tracking fertility and overall reproductive health.
Sure. AVA is a wearable, a wrist-worn wearable. So it's a bracelet that's actually only worn while you sleep. So if you're a night shift worker, it can be worn during the day, but for most women, it's probably going to be at night. And as long as you sleep for 4 uninterrupted hours, the bracelet gathers enough data through 3 sensors to actually provide personalized, biofeedback-driven, machine learning-driven predictions of your fertile window. So this is not just the calendar method where it's give us the dates of your last menstrual cycle and we'll tell you without knowing anything else about you when you're ovulating. I started out trying to use the calendar method. And for me, my partner and I really weren't getting pregnant. I previously shared that I had pelvic inflammatory disease. I wasn't sure whether it was something with uterine scarring that could be causing difficulties getting pregnant, or if it was something else. And so that's where I really turned to Ava when I felt like my doctors were unsupportive. I went into my first preconception conversation with my doctor, and I asked her, so how do I maximize the chances of getting pregnant if I can? And her response was, well, don't put on any more weight. That was incredibly demoralizing, incredibly upsetting, and also not very helpful, not empowering in the least. And so that's why I started going out on my own and really trying to see what was out there to better understand. Prior to that, I've been on birth control for 10 years, and I had no idea how long my menstrual cycle was, when I ovulated relative to when I could get pregnant, none of that. I found Ava, and I was interested because I had known about machine learning and how it could be used in health. And then I started reading the peer-reviewed papers that Ava has published, and just really was pleasantly surprised by the rigor of the science that was happening there. So the bracelet uses a temperature sensor, a PPG or photoplasmograph sensor, which measures differences in heart rate intervals, which allows us to derive breathing rate, skin perfusion, heart rate variability, which is a measure of biophysical stress, and breathing rate. And so I started wearing the bracelet. I bought it. I started wearing it. And it turns out that I actually ovulate a full 2 days earlier than what is quote unquote normal. I say quote unquote because these have been studies that have been largely done on a very select group of individuals, right? They tend to be historically predominantly white women, predominantly women who couldn't be afforded the opportunity to come into the lab several times during a menstrual cycle, and also just what the historically male medical institution has labeled as normal. Turns out what's normal for me isn't what's normal for other women. So the algorithm, when you sync the bracelet after you wear it, the algorithm on the complementary phone app tells you, okay, you are either low fertility, high fertility, or peak fertility today. And it will actually predict, okay, we think that you are not ovulating for the next week. It'll show you in real time where it thinks you are in your menstrual cycle. And when it told me that I was ovulating 2 days earlier than I expected it to, my partner and I said, well, okay, let's try it. Let's see. And it turns out it was right. So since then, I've actually joined Ava's clinical research team, and I've been helping forward clinical research around women's reproductive health. So we have the first publication that showed how 5 physiological parameters change in real time across the menstrual cycle, parceling out the variance for specific individual differences. So we can show that there's a post-ovulatory shift in temperature. We know that there's changes in breathing rate, and all of these different changes over 5 parameters allow our algorithm to be accurate at predicting, so ahead of time, fertile windows with 90% accuracy. So it's been really cool. I feel like I'm really doing something to help push forward the medical field, especially from a more feminist women's perspective. And additionally, we've also showed that the device isn't just useful for getting pregnant, so to speak. It also can be useful if you're just trying to know more about your body. So if you, for example, I mentioned that I don't want to, get pregnant until I know I'm fully vaccinated, et cetera, again. So you could actually use the bracelet to just cycle track, to just understand where you are in your menstrual cycle and get to know your normal. And we've actually shown, based on some internal data, that women who do that, if they then switch to what we say trying to conceive mode on the app, they get pregnant significantly faster. And so, again, I think part of it is just knowing your own body and knowing when to time conceptive sex. And we also found that it's really useful for women who even have a diagnosed fertility condition. So in a recent survey, 26% of users who got pregnant using AVA actually had a previously diagnosed condition. So I think, again, it's just all about helping give back the data to women, allow each woman to be in charge of, in some way, what is happening in her body, know what's normal for her, and then feel empowered to have those conversations with her doctors if she notices something's not right. So the app also allows you to print out your last 12 cycles, and it shows, when you had ovulated and how your breathing rate changed, your heart rate changed. And so you can bring it to your doctor. And we've had anecdotally people who've come back to us and shared that when they brought it to their doctor's able to say, oh yeah, I see that you're not, we don't see this change that we would expect. That would indicate that you might have some thyroid issues. Let's do those tests. And sure enough, that was what was happening. So it's been a really amazing last 4 years that I've had the opportunity to work with this company and do this research. And it's been as cool as well to now, I don't want to say flip it on its head a bit, but take something that was designed for women and bring it to the general population and show how we are able to actually predict COVID-19 infection using these same sensors, different algorithm, but same sensors. 2 days prior to symptom onset in COVID-19 cases in 71% of those positive patients in our pilot trial. So that was a recent study that just came out of Liechtenstein, and we have a 20,000 person study now running in the Netherlands to further validate that algorithm, make it even more accurate. And interestingly enough, also look at some of these questions that we've talked about today about vaccination, immune response in pregnant women, and how those physiological parameters may or may not change for women who are, say, on hormonal birth control versus normally menstruating women versus women who are menopausal. So it's really, really exciting to be part of this research. And, I just thank you again for inviting me to share a space and time as part of the discussion today.
Yes. And I absolutely love it. I think that we will continue, obviously, to see the effects of COVID-19 and this vaccine and what it does on birthing people and our overall reproductive health as things continue to come out. So I love what you do. And I'm sure that the research that you do, as well as everyone else is finding, is going to help just continue to push us forward for those of us who, especially as we navigate what post-COVID looks like for each and every one of us. So I thank you again for being on the podcast, and thank Ava Women for sponsoring the episodes in May, and as well as this episode. This is a great partnership. And for those listening, you all are welcome to get a discount on Ava Women. You can use the discount code Ava Sisters, AVASISTERS at avawomen.com. Let them know that you found the episode here helpful by purchasing your own fertility tracker. I know it's going to be a big blessing to you as you try to conceive and you just really want to know about how your hormonal health being off of birth control. So thank you again, Brianna. This was a pleasure.
Thanks, Erica. It was my pleasure. Happy to be here.
Awesome. Thank you so much for listening to today's episode. There are so many ways to connect with the Sisters-in-Loss community. Join our monthly support group, our Sisters-in-Loss Healing Collective at sistersinlosshealing.com. Join our free Facebook group at sistersinloss.com/community, or text Sisters to 797979 to download your free Journal to Healing ebook. That is Sisters to 797979 to download your free Journal to Healing ebook. Follow us on Instagram and Facebook at Sisters in Loss, and subscribe to our YouTube channel. Yeah, girl, we on YouTube at Sisters in Loss TV. We love you for listening. Keep the faith. Until next time, this is Erica, and I'll talk to you soon.